reproductive pathology. So for this section, we're going to start with imperforate hymen. For imperforate hymen, all that it is that we have an incomplete degeneration of the central portion of the hymen. And so what happens is that the patient's going to present usually around, I'd say around puberty, right? So around like 12 or 13. And the female's going to come in and she's going to present with a vaginal bulge, okay? And it can be smooth and it's palpable mass that's anterior to the rectum is another way that they could define it, right? And so all they're trying to say is that there's a bulging that's coming out of the vagina. And so all that it is that there's an accumulation of menstrual blood within the vagina behind the hymen, all right? But since the hymen was not degenerated, that means that the blood's going to accumulate and it's going to form this like bluish, reddish bulge, okay? And they call that hematocolipse, all right? I know it's really weird to pronounce, but that's what they call it. And that's all that they're going to tell you. So if you have a patient that comes in, she might be 13, 14, and she still hasn't had her period yet. And the question is going to say, she's had amenorrhea, but then you do a physical exam and you see a bluish bulge, okay? And that's odd. And then you also see it that it could be anterior to the rectum, right? So they're just talking about the location of the vagina. And they say that there's a palpable mass located at the anterior rectum. Then you know that they're talking about an imperforate hymen. And it's just causing a hematocolipus, all right? That's leading to the buildup of the menstrual blood behind the hymen. All right, and it's causing a bulging of it, all right? So that's all that imperforate hymen is. Next, we're going to talk about cervical pathology. The only cervical pathology that really, truly matters is going to be dysplasia and carcinoma in situ, all right? Now, the question is, why does this matter? What are they talking about? So let's take a deeper dive here. So within the cervix or any outer location of our body, so what does that mean to me? First, let's take a step back. Any location of our body that is in touch with the outside, for example, the oral cavity, the anus, as well as the cervix. These are three locations in which we see a transition zone. And the reason behind that is because when we're outside exposed to the environment, the outer portion of our body is going to want to have stratified squamous epithelium to protect it from the environment. And as it transitions towards the inside of our body, like as we go from the oral cavity down towards the esophagus, or as we go from the outer anus to the inner anus, or same thing with the cervix, right? We're going to have to transition because stratified squamous is not appropriate to be had within the body, okay? So we have to transition to columnar, all right? Now, that transition zone from stratified squamous epithelium to simple columnar epithelium is going to be a problem. It leads to an increased risk of cancer because at that transition zone, we have two different cell types kind of competing. And so it becomes a hot zone for cancer. Now, specifically at the cervix, we can get dysplasia and carcinoma in situ at that specific location. But it usually is secondary or associated with an infection of human papillomavirus, HPV, all right? And we recently found this out in like the recent years, like about like 20 years ago, 30 years ago. They're like, wait, there's a virus that actually leads to increased incidence of cervical dysplasia and cancer, carcinoma in situ, right? So they thought, why don't we make a vaccine for this virus in order to stop cancer? And sure enough, it worked out. So it was the first time ever we actually created a vaccine that can stop cancer. So that's why it was such a huge discussion. It's probably why you even know about HPV leading to cancer and why the HPV vaccine is so important. So let's take a little dive into what we're actually talking about here. So it's associated with HPV 16 and 18. Those are the strains of HPV that are essentially associated with dysplasia and carcinoma of the cervical pathology, right? And they have these specific genes, E6 gene product and E7 gene product. And you have to know the E6 gene product inhibits TP53 within the humans. And the E7 gene product inhibits PRB, retinoblastoma, all right? So these genes that they're inhibiting actually lead to the cancer, right? Because HPV 16 and 18 have E6 and E7, which can inhibit TP53 as well as RB, that leads to the potential risk of carcinoma, all right? Now, what we can do is a pap smear, all right, to see what's going on within the female, all right? If we can do a pap smear of that cervix, we can look for the specific cells known as koilocytes. So make sure you know what a koilocyte looks like because they will show a histology image of koilocyte. But we're looking for a koilocyte because the koilocytes are pathognomonic for HPV infection secondary to cervical carcinoma or dysplasia, okay? So you have to keep that in mind. Koilocytes are so important, all right? Now, what happens is that the patient will also present with postcoital vaginal bleeding, all right? And that's another pathognomonic thing for cervical dysplasia or carcinoma in situ. So be aware of these. Now, once again, as we said, HPV is the highest risk factor for cervical dysplasia and carcinoma, but there are other risk factors as well. If you have multiple sexual partners or started having sex earlier on, that just means that there's going to be probably potentially multiple sexual partners. then you have to start thinking of an increased risk of cervical cancer, or dysplasia, I should say, and carcinoma in situ, because that increases your risk for HPV. HPV is just a virus that's sexually transmitted. So if you have sex earlier, or if you have sex more with more sexual partners, then that increases your risk of having HPV, which then in turn increases your risk of having cervical dysplasia or carcinoma. All right, you got to keep that in the back of your mind. Another risk factor, which is something that everyone forgets about, but it's very high yield, they like to talk about, is immunocompromised patients. If a patient comes in with HIV/AIDS, immunocompromised, then you know that the patient's at increased risk of HPV, all right, which can cause a cervical pathology. All right, so keep that all in the back of your minds. You have to understand it. And then the way that we can differentiate this cervical carcinoma in situ is through the CIN system. The CIN system is going to go CIN1, CIN2, and CIN3. 3 is the worst, essentially. Okay, 3 essentially means that you've reached carcinoma. CIN1 is the earliest and the most mild form. And what happens is that we actually have coilocytes or abnormal cells starting to form near the basement membrane. All right, but it doesn't break through the basement membrane. If there's only cells located near the basement membrane that are abnormal, that means we call it CIN1. Okay, that's the differentiation. CIN2 means it's starting to spread towards the apical surface of the epithelium. And then CIN3 has officially reached the apical surface. So now we have abnormal cells that are at the basement membrane and have reached the apical surface. And right when it breaks through the basement membrane, then it becomes the carcinoma. All right? So I know that might be confusing, but all you have to remember is that expansion of those atypical basal cells towards the epithelial surface is indicating a CIN3 situation. Okay? So whenever you're near the apical surface, if there's abnormal cells near the apical surface, then you know that you're in a CIN3 differentiation for cervical pathology. All right. Once again, you're going to use that pap smear to detect cervical dysplasia before it progresses into invasive carcinoma. All right. Very important. That's all for cervical pathology. Make sure you understand HPV, and I would watch the HPV video on Sketchy in order to fully understand the questions that they might throw at you from a microbiology standpoint.